Good evening, Endo Summit Live, and welcome to this very exciting edition. Tonight is all about the bladder. And why talk bladder when you're talking about endometriosis? Because the bladder is a massive sensory driver to the pelvis. So this evening, we are talking all things bladder, which really is all things about your pelvis. Please welcome this evening, Dr. Maurice Chung. Dr. Chung, do you want to introduce yourself? Oh, we got to have a microphone.
I am a urogynecologist and also focus on interstitial cystitis, pudendal neuralgia, and endometriosis and chronic pelvic pain. Currently, I am at West Virginia University in Wheeling and Reno Hospital. And I have spent about 25 to 30 years in the subject matter that we're going to discuss tonight. So hopefully I'll learn something. If there's any questions, I can answer you.
Yes, it's not only my favorite topic, but your favorite topic as well. Also joining us is Dr. Yaniv Larish. Dr. Larish, can you, as if you need an introduction, but can you introduce yourself?
Hi, everybody. It's Yaniv Larish from New York and New Jersey, urologist specializing in pelvic pain with a special focus on bladder dysfunction as a sequela of endometriosis.
And also joining us this evening is Dr. Vidali. Dr. Vidali, as if you also need an introduction, but do you want to go ahead and introduce yourself?
I am a reproductive endocrinologist, reproductive surgeon, reproductive immunologist, and I'm really excited about being here tonight to hear what our guest speakers have to say about this very important topic.
Yes, so, I mean, the bladder. Where shall we start? Dr. Larish, do you want to talk about evaluating someone for bladder
Sure.
endometriosis versus bladder pain?
Sure. So, my philosophy when it comes to pelvic pain is that the bladder is sort of the canary in the coal mine. That is to say that just like with the canary in the coal mine, the canary can suffocate from lack of oxygen or can be dropped on the floor. There are many reasons why that canary doesn't survive the coal mine. And I think that the bladder is very similar in the same respect, meaning there are many reasons to have bladder pain, and untangling that mess, trying to figure out, being the sleuth, being the detective, to sort of untangle that really terrible knot of yarn and pulling on all ends to try to unravel the mystery of pain requires a special eye towards the bladder.
And Dr. Chung, how did it come to be that, you just became so focused on the bladder?
Well, it's a long story. To make it short, back in the late 80s, when the laparoscopy was just started, and we thought that we could use diagnostic laparoscopy to look at the abdomen, and then when we found the endometriosis, we burned them. And after I burned them, the patients still have pain, and then I changed my method to excisional surgery by about 1993. And after I excised all the endometriosis, patients still have pain. And then it came about some medication from the overactive bladder medications. They call it Detrol, came out in 1993. And there were a lot of endometriosis pelvic pain patients. They have the symptom of urinary urgency frequency. And I found that was very interesting. So then I move on and try to figure out why those two patients, the group of patients, have the similar symptom. So then I look into how to diagnose interstitial cystitis, the painful bladder, in that time, back in the early 90s. They said, well, you do hydrodistension. So then I put my patient through laparoscopy, excisional surgery, and the hydrodistension. And then the first paper, I looked at 60 patients that was published in 2002. Out of the two group of patients, well, the same group of patients actually, close to 90-some% of those have endometriosis. Biopsy confirmed all the history. And there's a 90-some% of the patient have the similar diagnosis of interstitial cystitis. I said, no way, this is not true. There's no way such thing happened. So then I went into more of the research and then figure out, yeah, it was true. And the second paper published in 2005 in the Journal of Society of Laparoscopic Surgeons, close to 85% of those patients have positive painful bladder syndrome and also endometriosis. So I call them evil twin. So there was a professor, Dr. Karen Berkeley, back in the similar time, 2003. She is a neuroscientist and focused on research. And she found out, with the mice that have a sham group, and then there's another group that was implanted endometriosis omentum. And she found out that the mice that have the omentum implanted with uterine endometrial tissues, that they have a lot more symptom of urgency and frequency. So I found that it was very interesting in animal and a human being. And that's how I focus on the IC and endometriosis, the coexisting. And that's when I first started.
Excellent. So, Dr. Vidali, you're an endometriosis surgeon. How many patients come to you and part of their chief complaint is bladder related?
Well, one of the things that we do is we request that patients fill out a questionnaire. And in this question, we have a specific bladder questionnaire, which addresses bladder-related issues. And I think that's very important because that helps us discover, not just generically, but in a sort of like scientific fashion, what percentage of patients have additional bladder problems. And, we're in the process of doing a research on this topic, but I can tell you that at the present time, more than 50% have significant bladder symptoms. But, I'm sure that Dr. Larish may want to expand a little bit more about this questionnaire and what the meaning of the questionnaire and what the questions are on the questionnaire. You're muted.
Even the computer doesn't want to hear me talking, so it mutes. We use something called the AUA symptom score, which is a validated 5-question questionnaire that is used to assess how severe someone's bladder symptoms are. And I can share with you some of those questions. One of them is regarding incomplete emptying. For example, over the past month, how often have you had a sensation of not being able to empty your bladder completely? Frequency. Do you find that you're going to the bathroom less than 2 hours after you finished urinating? Intermittency. Do you start and stop and start and stop while you're urinating, almost in a staccato pattern? Urgency. Do you have to run to the bathroom or can you hold it? Weak stream. Is your stream not as strong as it used to be, or does it feel like it trickles versus goes? Are you straining to pee? And are you waking up in the middle of the night to urinate? And we score those questions on a scale of 1 to 5. Of 0 to 5. 0 being never, and 5 being almost always. And then we sort of put people into different categories. If you're scoring between a 0 and a 7, we consider you mild. And that's, for the most part, normal. Most people would not treat somebody with mild AUA symptom scores. If you score between an 8 and a 19, then we consider that moderate. And if you score above a 20 to 35, then you're considered severe. And I can tell you that endometriosis patients in general usually score pretty high on these surveys. And the reason that they score high is related to two things. One, it's related to the direct impact of endometriosis on the bladder. And two, it's related to the impact of endometriosis on the nerves that govern the bladder. So an indirect effect on the bladder via the nerves. And if we think of bladder pain and bladder dysfunction in the context of direct versus indirect involvement, it's very informative in trying to figure out what the best thing to do for a patient is. We used to believe that a lot of bladder pain was mucosal, was coming from the inside of the bladder. And I used to believe that as well. That was the classic teaching that was taught. The reality is that for most of the patients that we see in the world of endometriosis, the likelihood of them having mucosal disease is relatively low. The likelihood of them having muscular disease of the bladder is pretty high, meaning the actual organ of the bladder rather than the inside is pretty high. And the chances of having nerve involvement is almost, it's almost always to some extent. And so the way that we go about treating patients like this is dependent on where we think where we believe that the disease is hiding and what it's impacting. One of the ways that we elucidate that information, one of the ways that I, in consultation with Dr. Vidali, talk to patients about this, is we ask questions that sort of unmask clues and hints as to where the disease is hiding. So for example, in someone who has a mucosal disease only, that would be somebody with interstitial cystitis, for example, without endometriosis being present. The patient who has interstitial cystitis and whose mucosal involvement only will almost always relate to you that their bladder hurts as it gets full and their pain gets better as they empty. When we take patients that have muscular disease of the bladder, they don't obey that rule. So we can sort of rule out and parse out who's going to have, who we believe is going to have interstitial cystitis versus not, or mucosal involvement versus not, or bladder muscle involvement versus not, or nerve involvement versus not, depending on how we go about asking our questions. And it's a very detailed history that needs to be taken in order to figure it out. So I don't want to monopolize the time, but in general, that's how I think about bladder pain syndrome.
Dr. Chung, how might you approach bladder pain in the person with endometriosis that might be a little bit different? Because one of the exciting things about the way that we interact educationally is that there's a lot of different opinions and we like to share them all.
Well, let me share with you about how I came to the way how I set up an algorithm. Because I look at the bladder symptom, pelvic pain, something if I can just treat that in the office setting or some minor procedure, I can knock out the symptom, and then that tells me this is the pain originate from the bladder, or the pain originate outside of the bladder and refer to the bladder through the central sensitization. So that's where I started. So basically, it's very simple. I used that for the last 20 years. In the beginning, I did not include the nerves in the algorithm, and now I did. So I started out to perform, of course, I have all these questionnaires like the PUF score, the ICSI score, the AUA score, and there's 1, 2, 3, and the visual analog score. So I would examine the patient and score all the pelvic floor muscles, the bladder, the pudendal nerve, which is ischial-spine. And then I will, if they have symptom, it doesn't really matter now because I'll just examine them, see where they're at with the score, instill the anesthetic into the bladder. By now, I hope that many of this audience know what anesthetic challenge test means. And so, no, okay, I have to explain. Okay, put some anesthetic in the bladder. And if the bladder pain goes away, well, obviously, that pain came from the bladder. So if the pain diminish, and I'll see exactly the score on whatever side, or maybe it's completely gone, or the patient's symptom was gone. And so I don't care whether it's IC, whether this is mucosal or the muscular, or the endometriosis or pelvic pain, the pain's gone. So that's what we want, right? So all you do is just the little things, and then the pain's gone or diminish. And for those who did not respond to the test, so I suppose their pain probably coming outside of that system, maybe from the pudendal nerve, maybe from the myofascial pain, endometriosis, whatever you gotta call it. So I'll send those patients for a different algorithm, and I guess I can elaborate a little bit later. Do you want me to do it now or later?
Well, what are you allowed to do? I want to stop everybody here for a second.
Yeah.
Okay. Because Dr. Chung brought up something that was super interesting for us to talk about. I want to get Dr. Larish's and Dr. Chung's opinion. So Dr. Chung says, or he just said, that if you have pain, you put the anesthetic in, the pain goes away, the problem isn't necessarily fixed, but the problem has a solution. Dr. Larish, do you feel that, and it's a big debate in physical therapy also, do you feel that you need to know the exact cause of the pain, or do you feel that if the person has relief, it's enough?
Yeah, I mean, it's a very valid question. I respect Dr. Chung's opinion. I'm standing on the shoulder of giants here, right? So, and I recognize fully that I'm not. So, my take is a little different though. And the reason it's a little different is because the application of anesthetic into the bladder via a catheter will only diminish pain that is mucosally generated, meaning it's coming from the nerve endings that are lining the inside layer of the bladder. That anesthetic is not going beyond that area by definition. And if that's true, that means that what we're treating with the anesthetic is interstitial cystitis, which is great. The only problem is that and I'm saying this through the lens of somebody who sees endometriosis almost like a tertiary referral center, right? So I'm biased in this way. Because the local anesthetic will only treat mucosal disease, and in this case, really what we're talking about is interstitial cystitis. The patients that don't have mucosal disease are not going to benefit from the application of anesthetic, and in fact, will likely be caused detriment to. And I say that because poking the inside of somebody's bladder when they have other sources of bladder pain, putting a catheter in, will actually set off a major chain of events that actually ends up with causing the patient pain. And, nobody wants to see that happen. We just don't want to see patients suffer more. They've suffered enough. That's why they got to us in the first place. So to answer your question, Sallie, in the least long-winded way possible, it depends on whether or not you're a Band-Aid kind of person. If you're a Band-Aid solution kind of person, meaning as the patient, if you want a Band-Aid, you want something that will make the pain go away, but you fully recognize that it's probably not the ultimate solution to take care of the problem definitively, then the Band-Aid solution is great. I don't have any problem with it. I'm not a Band-Aid solution kind of guy philosophically, right? And of course, the debate is going to rage around this point, but that's my take on it.
I'm not a Band-Aid solution kind of patient or kind of physical therapist, but I have to also say that I have seen patients who have had 9, 10, 11 surgeries, and they're constantly chasing, it's got to be one lesion. It's got to be one that, and I'm not saying you guys go and chase that. And I think that oftentimes people don't realize it's okay to choose what's getting them out of the pain rather than constantly grinding. I got to stop. I got to find it. I got to find it. I got to find it. And by the way, that hunt also creates a pattern from the brain to the pelvis that spasms your pelvis and creates its own pain. So I think the discussion is that people should be aware of all choices, which is why we're having the discussion in such an open way. But it is not always, I have to operate. And it's not always, I have to shove a nerve medication over something. You have to come to the solution for what works with a patient. Dr. Chung, do you want to respond to Dr. Larish?
Absolutely. And I was taught as any GYN surgeon to perform surgery, and I didn't trust anybody else that done surgery before. Even though you have done one surgery, two surgery, and many times when I go in the past, like number 3, I only do one. When I don't find anything, it's not there. But why? So the algorithm that I have, that doesn't mean that I abandon the serious illness. I'm just trying to sort it out what part of the pelvis are involved in the anti-pain syndrome. So, as I said, when I have instilled this medication into the bladder, and, of the 30 years, and I have done a couple of abstract, and finally have some numbers, which I've been trying to throw it out. So let's say I have 100 patients that have bladder symptom, urgency, frequency, pelvic pain, dysmenorrhea. 85 of them will respond to the anesthetic challenge test. About 20, let's say 80, 20 of them did not. So, okay, well, is it from external? Yes, it could be an external. So I'll put them through bilateral pudendal block under fluoroscopy. Okay, so let's put that aside. And the group of patients have 80% response to the anesthetic challenge test. Out of the 80, let me see here. Out of the 80 patients, after they've been tested and treated for a regimen, 84% of them, the visual analog score improved 50%. Okay, now, it's not by asking patient how much you feel. It's actually, it's not really a visual analog score, but I use them to score from 0 to 10. And I examine them, map all the pelvic floor muscles and bladder. And everyone 10, if they start out with 10, maybe the right side goes from 10 to 0, the bladder drop from 10 to a 3, and then the left side, the muscle drop from 10 to a 3. So now there's a component of the muscle and the bladder directly linked together on the left side of the pelvis, whereas the right side was completely gone. So before I go further or doing laparoscopy, which if they already have so many laparoscopy, maybe I'll just do one or maybe not, that depends on the patient. But for those premenopausal, that means have period dysmenorrhea, I will do a laparoscopy surgery after I drop the pain level down first, because you don't want to upregulate all the symptom when they have pain. You do a surgery, oh, there's no endometriosis, it's all gone. It's all scar tissues. Then whatever surgery I've done may make it worse. So the surgery come at the end. And so anyway, that's the approach. For those patients who have the pudendal block and the whole algorithm at the end, 85% of those patients would have at least 50% improvement. And there are so many of them, the pain actually gone. Now, would they have it back again? It's the nerve. They probably will, but they know what's wrong, so they're not that desperate.
I'd like to ask the panelists, we've talked about bladder installations, but in reality, we see a lot of patients that have not even attempted any sort of medical approach, pharmacological approach to bladder problems and bladder spasm. And I think we need to mention those, because there are effective medication that exists that should be tried before any of these invasive approaches are put in place. I don't know if the panelists would like to talk about that. You want to start, Dr. Larish?
Yeah, sure. So, in my view, and again, I subscribe to the philosophy that it's overactivity of the bladder and bladder spasm that's generating a lot of pain. Because if you don't believe that, then the medications that we prescribe are not going to help, right? If you don't believe that that's really what's happening. So I do a multimodal approach. The first step is to control the bladder spasm and the overactivity, and that's with either one of two classes of medications. The first class is called the anticholinergics, of which Dr. Chung alluded to. The Detrol came out in the 90s, Ditropan, tolterodine, oxybutynin, belladonna, and opium. The list goes on and on and on. All of those medications have a similar set of side effects. They're very efficacious, they're very effective, but they all have a similar side effect, which is dry mouth, dry eye, and constipation. The problem with these medications is that if you have constipation in the setting of overactivity of the bladder or spasm in the setting of constipation, you're going to make that worse. And so it's very important to always ask, the way that Dr. Chung asked, the ways that I asked, the way that you asked, Dr. Vidali, is, do you have a normal, smooth, soft bowel movement every day? And patients will say, oh, no, I have a bowel movement every day. And say, well, is it hard like little rocks, like a rabbit? Or is it soft and smooth that it all comes out? So you have to be careful before prescribing the anticholinergics because they can make things worse. The other problem with the anticholinergics is dry mouth. And if you think about, if you had terrible dry mouth, what would you do? You would drink. But if you drink, now you have to urinate. And so it's sort of this vicious cycle. So about 7 years ago now, they came out with a drug called mirabetrol or mirabegron, which is a different class of medications from the anticholinergics. It's called the beta-3 agonists. And it doesn't have the dry mouth or the constipation or the dry eye. It comes with a different set of side effects, which is a slight elevation of blood pressure. There's another medication that came out recently of the same class called virabegron. Just like mirabegron, it works the same way. It's a beta-3 agonist. I think what's interesting about these drugs, if we talk about sort of the context in which these medications work, there's a framework for thinking about bladder pain and bladder dysfunction that was championed by Dr. Erwin Goldstein in San Diego. And he talks about sort of end organ dysfunction versus pelvic perineal dysfunction versus sacral nerve root dysfunction versus spinal cord dysfunction versus brain dysfunction. And what's interesting is that the anticholinergics work at the level of the bladder. And the beta-3 agonists work at the level of the sympathetics, the spinal sympathetics. And what's fascinating to me about that is that I think that if we could match, ideally, the patient with the symptoms being driven by the end organ dysfunction to the right medication, and the patient being driven by the sympathetics to the right medication, we might have a better control of the situation without requiring further intervention. Beyond the oral medications for bladder overactivity and spasm, we also tend to put patients on medications for nerve dysfunction. Neurontin or gabapentin would be a primary one. Cymbalta, sometimes at low dose, which is it's actually an antidepressant, but at low dose sort of helps to temper the overactivity of nerves rather than of the bladder. In patients where the oral medications don't work, there is always the option of administering a medication directly into the bladder in the form of botulinum toxin or Botox, the same stuff that people put in the foreheads to get rid of the wrinkles. It's a muscle relaxant. Instead of relaxing the muscles of the forehead, it relaxes the muscle of the bladder and therefore will also stop spasm and overactivity. And we have probably the most robust experience in the country when it comes to using Botox for that effect. But that's how I think of it, and of course, we don't jump to doing more laparoscopy on patients that have had multiple surgeries. In fact, I can tell you those patients typically get put into a different pathway that does not involve further robotic or laparoscopic surgery exactly for the reason that you're talking about, Dr. Chung. So we don't believe that somebody who has good surgery 3 times needs a 4th good surgery. It's probably not the solution.
Especially for bladder problems.
For bladder, particularly for bladder.
Dr. Chung, do you have the same experience with these medications? What is your experience?
So all these medication, like doctor was just mentioned, like multiple of them. And I have been to so many conferences back in maybe 10, 15 years ago. It's a very, very, very hot items, overactive bladder. So the problem is the overactive bladder also carries multiple symptoms such as urgency, frequency. They don't leak urine, or maybe patient have stress incontinence, which is coughing and sneezing, where Cymbalta is duloxetine, which actually was trying to use for treating stress incontinence. However, it doesn't really work because it doesn't really reach the significance on the results. So then you have urge incontinence, which is the one that hit the signal, oh, I gotta go, and then they leak urine. And 2003, I think it's 2003 and 2005, there was a paper that I actually written. It's how the anesthetic testing sorted out which group of those have a higher problem with mucosal defect. So basically, they sorted out that into overactive, dry, or wet. So the group that does not leak urine, just have urgency, frequency, all those symptoms, 70% of them have a mucosal defect. Whereas the group with stress incontinence, and they also have urgency and frequency, they have a little bit less mucosal defect. And the group with urge incontinence is probably only 40% of the mucosal defects. So you look at all these drugs for OAB to treat our patient with endometriosis. Let's talk about the younger group, because the urogynecologists, urologists sometimes deal with much older population. They are having the period. More than likely, that group of patient is more likely to have urgency, frequency, not necessarily dysuria. Sometimes they felt that they empty the bladder, they're better. And sometimes they said, well, you know, after they empty the bladder, they have bladder spasm. So if the medication on OAB that we offer, that only improve 25% of the symptom in general for urgency, frequency, not for incontinence. Almost all those medications, they try to make them look so much better. But ultimately, if a patient pee 20 times a day, they drop 5, 15. If they pee 30 times a day, have all the symptoms, they drop 25% of it. So that's a very good drugs to use. I mean, of course, I'll use it. And if those patients, that's why I'm saying, okay, I'm just doing a test first. So I test them, and some of those I do give them the OAB drug. But anyway, I agree with Doc, and OAB drug is an option. But most of the patients that we have seen, they all referral. They already been tried on OAB medications, or they already have surgical intervention a few more times.
Yes and no, Dr. Chung. I mean, we see a lot of patients that the bladder is completely ignored, right? So they've had, I mean, we saw a case just recently where the was under the joint care of urology and gynecology for years. And we said, okay, well, you know, you deserve a diagnostic laparoscopy at this point. No, nothing. She was just being sort of towed along. She had the biggest mass I've ever seen in a patient's bladder of endometriosis. Andrea, I mean, I don't know what you think, Dr. Vidali, but, you know, to have an undiagnosed mass like that for years is, I don't assume that anybody who's taking care of these patients actually has done the systematic sort of thought process that you and I go through, Dr. Chung.
Well, I agree with you on that. But I was just saying for medication, many of them have already been given the medication. And which is bad when you have a mass of a couple centimeter in the bladder that you miss it. Ultrasound will not miss those lesions. And sometime, and the detailed history would tell you they have hematuria with the period. Now, let's not talk about older group of patients that postmenopausal, because the endometriosis group is not there, in my experience. So,
I mean, let's also say in the postmenopausal female, lack of estrogen is going to cause some bladder issues and some burning as well.
exactly.
So it's just going to add something into the mix of this webinar we might not want to see. So look, I'm going to refocus us for a minute. All right.
Okay.
Dr. Larish and I were, especially the endometriosis summit was brought into a urological association. And because they don't get enough endometriosis education, in the same way the endometriosis societies don't get enough urology education. So it's very interesting. So the number one question we get asked across the board is, how do you tell the difference between its bladder endometriosis or it's bladder driven pain? So I'm going to let you each answer because I know you're each going to have a different answer. Dr. Chung, you go first.
Well, if it's truly muscularis involvement, okay, then patient, they could have the urinary symptoms such as hematuria, which these are the major driven patients. And well, I get this blood in the urine, but nobody, they thought I have a UTI. And on top of that, they could have urinary urgency frequencies too. And so in order to sort that out, that's what I do. It's very difficult to just ask the patient, what are the symptoms? Oh, you get the muscle spasm, or you get the hematuria, or you get mucosal disease. It sounds too complicated for the patient and for me to try to find out. Well, cystoscopy needs to be done. However, cystoscopy was done. Sometimes the urologist would still miss endometriosis in the bladder because they sit outside on the other side of the muscles. So in order for me to try to answer the question, I check on with the symptom and with the test to see what direction I'm going. You see what I'm saying?
Right. Well, I found it very interesting in working with AUA last year. You don't really have to have bladder endometriosis either inside or on the outside of the bladder to have bladder symptoms, because you could have it all around your ureters. You could have it elsewhere and still have a ton of bladder symptoms. Dr. Larish, for you, how do you tell the difference bladder endometriosis versus bladder driven pain?
So before I answer that question, Sallie, you're selling yourself a little short. You won, first prize for patient advocacy at the American Urological.
No, not first prize. There were like 8 of us there, so.
Yeah, in the entire nation. So you were showcased. So let's give credit where credit is due. You did a beautiful, fantastic job there. So to answer your question, I think that, and I've shared a slide about this before, and I will share it again at this year's Endometriosis Summit. I think that parsing out whether it's bladder or the nerves to the bladder all boils down to the findings on cystoscopy, the findings on history and physical, and the findings during surgery. And between those 3 things, and there are many different flavors of how that we can figure that out. So for example, if a patient complains of episodic hematuria, the likelihood of them having, and whether that's gross hematuria that they actually see with their eye, or whether they have been identified as microscopic hematuria by the doctor, also plays a role. But that generally speaks to involvement of the inside of the bladder, the mucosal part of the bladder. In the absence of blood in the urine, then we start thinking about the muscular layer of the bladder, or perhaps the nerves that are governing the bladder. If they have rectal complaints and bladder complaints, then the root cause is likely in the nerves that govern both, in the hypogastric nerve plexus. If they have it in association with back pain, then perhaps it's higher up at the level of the sacral nerve root. If they have it in conjunction with flank pain, perhaps it's really ureteral involvement. If they have pain that gets better with emptying, then it's likely purely mucosal and just an interstitial cystitis, it's interstitial cystitis. If they have pain that gets worse with emptying, then by definition, it's not interstitial cystitis. So the appearance of the bladder on cystoscopy, the presence or absence of endometriosis during surgery, the presence or absence of blood, and the symptoms that the patient is experiencing, whether cyclical or not, all play a role in how we figure out where the lesion is and what the root cause is for the patient's pain.
So I could just jump in for one thing. You know, the history of the patient is important, but you know, all these patients, they have so many complaints and so many symptoms. And I tell you, I'm not a very good diagnostician, and you tell me a couple of things like urgency, frequency. Here, this pain, oh, I cannot pee, and sometimes I could, after a little bit longer, then I'm lost. So I try to go, that's why I'm trying to have the algorithm to try to help me to sort out all of these symptoms. And then
I have a good question for you and your algorithm next.
Okay, so go ahead.
All right, so first we get asked, how do you tell the difference? The next question we get asked, and one I personally experience, why is there so much leg pain with bladder symptoms, and especially in the endometriosis patient? So Dr. Chung, you're on because you're really how a lot of people I work with have figured out where this leg, what's the deal? What's the connection with the leg pain?
Well, you know, blood is S234, okay? And S234 on the pelvis, the nerve group is pudendal nerve. The back group is cluneal nerve. And pudendal nerve is S3, so it travels down and refer all the way down to the leg, whether that is the posterior or anterior. And sometimes, if endometriosis have leg pain, either there's endometriosis involving some of the deep sacral roots, or actually this is a refer pain, and the patient might have previous injury, just a fall hitting the buttock or the hitting on the sacrum that causing that segment of the nerve that somehow travel all the way down to the S3, which is you know, all this perineal or the big toe all the way down. And so I think it's a referral.
And sometimes we see also surgical damage, you know, like
Yes.
surgical effects. Yeah, let's mention that somebody had asked the question, right?
Yeah.
Surgery itself, the trauma from surgery can also activate some of these sacral.
Absolutely. So when you have the leg pain, to me, I know that it's more likely the pudendal nerve root is involved. At least. So at least I have a solution to go and nail that nerve. And patient, lower back pain. They say, oh, well, I went to see the neurosurgeon, or the doctor told me the lower back pain and the sciatica, and I give the pudendal block. I say, oh, my lower back pain's all gone. And my leg pain's gone too. I said, okay, that's good. So I don't know what happened, but somehow this injection takes those away. Patient have stone, have ureteral endometriosis that was fixed. Then they have urgency and frequency. Why the heck that even happened? It's all done. Well, you know what? That's upregulation of the bladder nerve. And the anesthetic, treat it. The nerve block, treat it.
Treated temporarily or permanently? Because that's a very important question.
Well, yeah, you have very good questions though, because you know what? If the nervous system get damaged, hey, we don't forget. It's like an elephant. So
Although,
this patient, yes.
Yeah, although there are two technologies today that go to sort of instead of, look, we're surgeons, right? Surgeons are destructive creatures by nature. Even the most reconstructive, delicate surgeons are the nature of surgery. So in our armamentarium, in our chest box, we really only have two tools today that are not destructive. One is the sacral nerve root modulator, what we refer to as the gizmo or the sacral neuromodulator. Or the
I take credit for the gizmo.
Yeah, Dr. Vidali.
We did ask the Gizmo company. We actually didn't just ask. We begged for funding, and we didn't get any. So be careful here.
We're not touting them. There are many companies that do it, so we're not going to tout one specifically, but we're just going to say that there is a way to modulate the nerves via the sacral root. And to answer your question, Sallie, about leg pain, there's actually a company now that modulates bladder dysfunction via the peroneal nerve, so through the ankle. Because there are the nervous system has the highway, and
which is brilliant. It's such a brilliant idea. It's fascinating.
So in stroke, they've been doing that a long time.
Yeah,
I did that in PT school.
This one, the new innovation that happened about 12 months ago now is that it used to be you could only apply that therapy in the office. So you would take a small acupuncture needle and access the nerve in the office and then apply.
12 times, something like that. And
right. Today, there's a new device called an e-coin, which actually is the size of like a dime or a nickel. And that gets implanted surgically in the ankle and it delivers therapy continuously. So look, to me, neuromodulation
it's the only nickel that is as expensive as a gold bar.
Yeah, but I mean, it just goes back to, for all the PTs tuning in, every patient we treated with a device for foot drop, you never needed to treat them for their bladder anymore. It's just a very different, it's just, it's like the same thing, but it's just repurposed.
Only when it works.
Right.
Only when it works.
Only when it works.
Right.
And actually those people wanted to come, and Dr. Larish walked away from their table when we were talking to them.
Not intentionally. I actually want to talk to them, so it's good.
So we'll go back in May and talk to them, but they really liked what we did because that particular company is really into the patient. So wait, Dr. Chung, I know you talk, first of all, I can say as a patient, the first time a PT treated the cluneal nerves, it was like little angels sang in my ears and clouds parted. And can you explain to people what the cluneal nerve is, but are there also other nerves? We've had Dr. Ahmed on. She talks a lot about the ilioinguinal nerve and the lateral femoral cutaneous nerve. How do those?
Yes. There's a whole bunch of nerve. That's why I call it pelvic system. It's like the bottom of the Christmas tree. It's so many branches, and you really don't know which one, or they all work against you. So whatever, just go back to the algorithm. The algorithm is to help to sort out the initial, how much involvement, and then you go with surgery, laparoscopy, or nerve block. And I do examine the patient's coccyx, the cluneal nerve, ilioinguinal, the left lower quadrant pain, right lower quadrant pain. After the nerve, after the blood installation, the bladder pain is gone. And left me with the left pudendal nerve. I said, okay, it's 4. I said, wow, I just give you a block. So who is to know that when I find out the trigger point, which is the left ilioinguinal nerve, I give them injections right there. The pudendal nerve pain went away. So there's a system that they connected. I think when pain happened, it's like the river flooded all the branches. You never know which one involved to begin with. So to answer your question, yes, the coccydynia, it's involved the cluneal nerve, which is the backside of the pudendal nerve, S2, 3, and 4. Don't forget neuromodulation when we keep poking the S3. If those patients have the neuropathy of the S3, sometimes they have a lot more pain of the IPG site pain that I have to explant them. So I'm not doing any of these neuromodulation, which I have to poke a lot, cut a lot in the back. If they have back pain on the right side, I'm not going to touch the right side. You put anything there, it's going to hurt more. So I try to do the left side. But before I even do that, I try to down-regulate all the nervous pain symptom so that at least I know there's something that is going to work. Now, for patient after the bladder pain goes away, they may still have urinary urgency frequency. Oh, that neuromodulation worked perfect. And that would work. So,
You know, there's always two schools of thought between neuromodulation first and neuromodulation after 9 million other things. And it just sort of, I think it depends on the case. So Dr. Vidali, we were here talking about sciatic pain and bowel endometriosis. We have a couple good questions off of Instagram and the Q&A here. What do you think about sciatic pain and the bladder?
Well, most individuals with sciatic pain do not have sciatic endometriosis. It's not on the sciatic nerve. Although it exists and we've seen it, we have treated it, it's very rare. It's very rare. So it's the same principle, which is it's usually a form of referred pain due to some form of like either nerve compression, due to alterations in the physiology, in the mechanics of the pelvis, due to inflammation, scar tissue, and whatnot. So they're all correlated. So it just kind of connects to what we've been talking about. So that's really my perspective, which is it's the same principle, it's the same problem. So whenever there's sciatic pain, I very rarely am prone to believe that it is, although it's worth looking for it, but it's most likely not going to be endometriosis on the sciatic nerve. And I think we'll be talking about sciatic endometriosis in one of our oh no, Dr. Tier was going to come to the other
Well,
side.
we have to see what happens financially.
All right. Okay.
So,
Go
I think that
Sally, sorry, interject. You know what? PT helps out those neuromuscular pain a lot.
Yeah.
So there's a big role for them to help us out. And when we are into the symptom, and sometimes working with them side by side, it actually helps to see, oh, well, what are the muscle group that's more involved? So I at least know, then I can probably try to do some trigger point on those muscle group.
I have a very, very, very quick question, but I think it needs to be addressed, which is the issue of occult bladder infection, because I think a lot of people will ask about it.
we got a guy doing that this year.
All right, so we're gonna guy doing that, but I think we need to mention that also that needs to be looked at, because you cannot exclude completely that as a possibility. And I think one of the more reasons to come to the endometriosis summit this year.
I'll take you one step further. Dr. Sarrel and I were at the SLS this year, and Dr.
That's
Chung
just
was
coming.
Yeah, but there was somebody in the audience who
That's
said
just coming.
it is all right. So in addition to doing the Urogen, the PCRs for the urine, he also said, hey, I find that a lot of patients have an old history of herpes simplex virus infection.
Yes, yeah.
And erupting sort of in the nerves, in the pelvic nerves, and that's where the pain is coming from.
Yes.
So, I think that our field is sort of nascent. It's just at its birth. We're sort of just coming into sort of what needs to be done for these patients, and it's going to be an exciting next couple of years as people figure this out more and more, and we all sort of strive to get these patients taken care of.
So and the endometriosis summit is trying to do that.
Well, it's interesting, because I think that I think urologists may be finally coming to the table that the endometriosis people aren't people to run away from. You guys have both lectured for a long time. Are you beginning to see a change or no?
Remember AUA make some new suggestions, Dr. Larish, that then there's the IC group, the rest of those, they should all be treated by a physical therapist for the improvement, right?
For sure. I mean, I don't know where,
But then AUA has one physical therapist there, and I'm talking in the patient's perspective. I'm talking as a patient when I'm there.
Sallie, it's not just urologists or gynecologists or general surgeons. For the most part, if you get a knee replaced or a hip replaced, you're prescribed physical therapy afterwards, 100% of the time. But if you do surgery intra-abdominally for whatever reason, whether it's endometriosis or a kidney, tumor, nobody prescribes physical therapy. And so there's a disconnect. There's a disconnect in the medical community as a whole from the concept of physical therapy. And I think now with the new recommendations by the AUA of involving physical therapists early, I think that's a tremendous stride. That should not be glossed over. It's a tremendous stride forward.
All right, let's take some questions. So I have one coming off of Instagram. What are the reasons, and I think that this is an important one, Dr. Larish and I were discussing this fall. What are the reasons that you could have loss of continence? So not just incontinence, but an inability to use your bladder functionally. Do you assume that's bladder endometriosis, or like the good clinician that you are, do you talk about it being something else, Dr. Larish?
Yeah, I think there's many reasons why an organ loses function, right? So the bladder's purpose, the way I like to think about what the bladder needs to do, it's got to do two things, and it's got to do them well. It's got to store urine, right? That's the storage component. And it's got to evacuate urine. It's got to empty well. And there are disorders both of storage and of emptying that sort of drive symptomatology. So if somebody has a very sensitive bladder that spasms with a small amount of urine in it, they have a storage issue, right? And that needs to be treated one way. And that's not necessarily endometriosis. There's many, many reasons for that to happen. On the other hand, if somebody has a bladder that doesn't squeeze well, doesn't eject the urine out when they need to void, or decides to eject the urine when it's not volitional, when it's unwanted, then you have a different sort of problem. And the way that we think about all of these different occurrences with the bladder sort of dictates the therapeutic choice for the problem.
I don't necessarily think that the loss of continence is from the endometriosis, unless that involvement of the nerve root is so much. You see what I'm saying? There got to be some other issue that connected with the patient. They're young. What about multiple sclerosis? All the other thing.
I never ignore the spine.
Yeah.
And it is amazing how many times, even when I worked in pediatrics, you've got like not a good spinal thing going on, and people have just gone to the urologist or the gynecologist, not the kid, but
Yeah.
Yeah.
Although,
all right.
We do see patients with incontinence secondary to endometriosis purely by involvement of either the bladder muscle to the extent that it's spasming because it's just hot and inflamed, or to the extent that the nerves are damaged from the endometriosis. And in rare situations where the bladder is replaced by endometriosis and doesn't function at all, doesn't expand the way that it's supposed to. So you get a smaller capacity bladder.
We also see, Yaniv, we also see sometimes cases where we've been talking about with a patient that cannot void. The patient is retaining urine and has this overflow incontinence. And those are the patients that do incredibly well with nerve stimulators. That's
yeah. If it's whenever
those
that
extreme
happens,
cases, we see those, and those are the cases of overflow incontinence, and those are often missed. We've seen people that have been treated for stress incontinence, and desperate people that have been mismanaged. We've seen that a lot.
So why might the bladder hurt from ovulation? So if you look on Facebook, Instagram, or the Q&A here, we have 15 different kinds of that question. I have my own answer, a lot of which we will discuss next week. But let's talk about the bladder and ovulatory pain. Dr. Chung, you go first.
So ovulation, there's a change of hormones, big time. And estrogen fluctuations. Ovulation, there's a surge of estrogen. And then, so estrogen is a known nerve growth factor. And so when there's nerve that's stimulated by the estrogen, actually they work through the dopamine first. Before that, I think dopamine is the one that inhibits the nerve growth factor, or the other way around. So when you have the surge of estrogen during the time of ovulation, the nerve become more sensitive. So we're not talking about why is it the bladder? Well, the whole pelvis depends on what was the cause to begin with. Is it endometriosis? Or this goes to the same thing with ovarian cysts. oh, I get ovarian cyst, I have this pain. Well, is it the true pain? No, it's the nerve pain. And a lot of people have ovarian cysts, they don't hurt. And why is it just you have ovarian cysts and it hurts? So I don't think that that is endometriosis related. And it's just the nerve, maybe the patient have some kind of previous injury, like just hitting, have a fall, riding bicycle, did something to the abdomen, muscles, that can stir up this kind of symptom. Alongside with leg length discrepancy, the pelvis wasn't stable, all these things can contribute to the underlying unilateral symptom. All patients have pre-C-sections, and somehow that injures one of the ilioinguinal nerve branches, and that side can hurt more, and ovulation on that side, and then they are related to the bladder. And that's my honest opinion on that.
We've seen a few instances where there are endometriosis implants directly overlying the hypogastric nerve in the pararectal space on either side. And I think that those implants get hot during ovulation, and hot meaning they get activated and sort of lit up, sort of like the Christmas tree over your shoulder, they get lit up. And then, it's searing hot pain wherever that nerve innervates, whether that's rectum or bladder or both. So that's one reason. The other reason is sometimes we see patients who've had large ovarian cysts. Ovarian cyst sort of invades into the pelvic sidewall, and the ovary actually becomes a retroperitoneal structure. And then when they get ovulation in that ovary, the ovulation is happening in the retroperitoneum itself, and it's pushing on all sorts of nerves. That's certainly a reason. And then you have lesions on the bladder itself that can become activated during ovulation. So, I think that's not an unreasonable thing. And I think, it's true there are plenty of people with cysts that don't have painful bladders, right? But there's plenty of people without cysts that have painful bladders as well.
But let's not forget, though, that idiopathic ovulatory pain is also a thing. Okay, because we don't always want to attribute ovulatory pain to some organic or physical problem. Otherwise, these people end up with endless surgeries looking for something on the ovary that does not exist. Idiopathic ovulation pain exists. It's a thing. It's real. And there are initial triggers, but then once it becomes a constant problem, it's real. And that's also due, which we didn't mention, that ovulation is associated with a huge release of prostaglandin. The ovary doesn't ovulate because of pressure. It ovulates because of release of prostaglandin. There is no pressure in the follicle. People have this idea of a burst. It's not a burst. It's a release of prostaglandin. And these people who are very sensitive to this prostaglandin will have idiopathic ovulatory pain, which is very common and can be associated with other forms of pain. So let's not forget that exists and it's real. Otherwise, we'll be looking for things that are just not there.
I break it down, a little more simply because I'm not an MD, but I think that the ovary is so close to some of the nerves and the release of prostaglandins, the mechanical nature of sometimes ovulating onto an ovary that is already diseased, sidewall disease. You're going to have this sort of like talking to with the ilioinguinal nerve and even the lateral femoral cutaneous nerve and just fire everything up. That's how, and you're also going to have probably an obturator internus spasm from the entire activity that goes on. And that's going to cause its own pain. All right. So this is bladder night. We may have to do another bladder night because we not only had about 60 on here at one point, we are out to close across the 3 profiles to 45,000. So that's pretty good. I love to tell my sponsors that. But what it says to me is we need to do more talking about the bladder and the pelvic pain and the endometriosis patient. If so many people need this information, we need to be talking about it more. That's really what it says to me. You're muted.
So many questions. I didn't even get to answer.
Well, you
them.
you can answer them after we shut the recording off. You're welcome. We usually do stick around. But what happens is after that hour, our numbers really drop. So, so as we wrap up, let's talk about the Endometriosis Summit. So we extended pre-sale for this webinar. Pre-sale will stop January 4th at midnight. So you have now and tomorrow to get in on pre-sale, and then ticket prices are going up. There was no way around it unless like a sponsor falls from the sky. But ticket prices are going up. So things that you will get an entire hour, I believe it's an hour, it might be 50 minutes on the bladder during Endo Summit surgery, and added to a discussion with Dr. Larish and Dr. Chung will be a discussion with Dr. Waters, who will talk all about sort of like latent microbes that hang out in your bladder lining and drive you crazy. And plenty of people have surgery looking for help, and it's really these microbes, or even the lots of little viruses in your bladder. And also during that hour, you'll be joined by Tracy Scher, who will discuss very specific physical therapy techniques to the anterior bladder. And I've seen what she's going to talk about. I have been treating endometriosis for 15 years. I only treat endometriosis, and I had never seen the techniques and I never heard the discussion that she's going to have. So if you're a physical therapist, it really is something you will really enjoy. We also have a full day of workshops. We're going to have a social event. We're going to have movie Under the Stars. Dr. Vidali will be there, we assume. Sometimes we think he'll be there. And we're going to have a room. We're going to separate it out, but we will have a support group for miscarriage. That is new this year. And we're going to have a discussion on adenomyosis, lots of fun things. Jillian Gilchrist is our keynote, where we'll talk about politics. Dr. Chung, what are you looking forward to the most about the Endometriosis Summit?
Oh, last year I thought that I could be there, but this year I'll be there for sure. At least that trying to listen and have a good discussion, meeting some of the colleagues. And I guess I don't expect too much at this point, but I know it's a good summit. And because it showed last year and many years before too. So I'm very much looking forward to go there and getting out of the cold place in West Virginia, going to Orlando, a little bit warmer too at that time.
Yeah. Dr. Larish, we are turning 5 in March 1st. So what are you looking forward to about the Endometriosis Summit?
I'm looking to see the exponential growth that I see every year at this summit. So it started with a couple hundred people in a room, then a couple of hundred people in a room, and then a few more hundred people in a room, then online. All of a sudden, we're reaching 45,000 people for an impromptu bladder discussion.
For an impromptu bladder discussion.
It's mind-blowing to me. So
Yeah.
I'm looking forward to see how many lives we can touch and educate and learn from each other, and sort of in the spirit of collaborating on finding a positive way forward for patients with endometriosis in the United States in 2023.
Excellent. And Dr. Vidali, what enthralls you about this year's Endometriosis Summit?
I think that we are advancing the science. We are advancing the perspective, the way of understanding this disease. It is a surgical disease, but we go way beyond the surgery. We look at the science and we learn from both patients and practitioners. And I think that's what makes it very unique, and I think that's really the great value of the Endometriosis Summit.
Right. Okay. So just for now, I'm going to shut off the recording. We had a wonderful evening. Some of you may want to hang out and see if we get to your questions. Otherwise, we will be back next week. Next week is my favorite week. Not that I don't love you, bladder people. Next week, we are talking we're going to have a whole hour on leg pain. And we are going to be here with Dr. Fogelson, who is gonna, there's a couple questions on vascular compressions, and I swiped those off of our Q&A because he's going to talk about vascular compression and endometriosis. We are hoping that Dr. Zolan will join us talking about occult hernia and nerve compression, and also Amanda Olson, a physical therapist, will join us as well. And it'll be leg pain night. So that is next week. And we'll see you guys then.
Bye-bye.
All right. So my record.